result can be being discriminated against, living in segregated housing, in segregated schools, and basically the long-term impact of being faced with constantly dealing with being treated on a less than. The cumulative stress, the repeated assault of living in a racist experience has not just a psychological impact, it also has a physiological impact. That there are hormones that's released when you're constantly having to fend for yourself or to defend who you are. That it has a physiological impact on the body. And basically what we also have learned is that there is a relationship between a relative sense of control over your life and how that impacts your health. So the less sense of control you have over your life, the worse your health status might be. And with the area of food, this really tends to play itself out. Because what we've also, in our studies, we do a lot of research at Polic. And a lot of the research shows that when people have less control over their food, now with all of the changes happening with people in their struggles with economics and whatever, food tends to be the place where they can have some control over their lives. And so when you start to take away the control that you have over what your food choices are, you know, health tends to go by the wayside. And so we have to figure out how to make sure that when we structure solutions, that they take into consideration some of the cultural interests and needs of the populations, that we don't want to create obesity strategies that are contrary to people's cultural beliefs and patterns of what they're going to be eating. And I'm going to talk a bit more about that a little bit later, but all of these things have contributed to this sense of health impact by these various factors, and basically making the case that environments are critical influences on behaviors, whether directly or indirectly. This slide is basically showing, again, as we've done our research to understand how health is impacted, that what in policy we call communities of opportunities, those are communities that have well-functioning parks, and they've got grocery stores, and they have banks, and they've got good performing schools with AP courses, and they've got good transportation. On the other hand, you've got low-income communities and communities of color, as rather than having grocery stores, they've got mom-and-pop stores. As opposed to banks, they've got check cashing places. They don't have parks that are safe. And so those they don't have quality child care. They don't have, the schools don't even offer AP courses. So the kids leave those schools not being well trained, not because they're not smart, but because they didn't have the same opportunity. So we look at how opportunity structures make a difference in a person's whole life course. And that's why we've got to begin at an early age, because what you begin to form in childhood has a long-term impact on your perception of food preferences, on your life behaviors and choices. And so we've got to take a look at how to make some changes happen, because these are social justice issues that we're trying to tackle here. So when we started to do our research at Polic, we did an extensive amount of interviews with researchers and policymakers and practitioners across the country. We interviewed the leading researchers who've been doing research in this arena around health disparities for a number of years. And through talking to them and reading our own literature and understanding about what is happening across the country, we developed a framework for how we began to understand how the community impacts health. So that is what I call is health in place, is looking at how place impacts health. So when we looked at the contextual factors, the factors around race and ethnicity and economics, and then we put that together with what are the components in place, what is it that needs to be in place in the communities to ensure good health? We identified that we had to look at economics, the economic environment, the economic status in the community, the social networks that people have within those communities, the fiscal environment and its health of the fiscal environment, and the degree to which there are services that are culturally relevant and that are neighborhood-based, and that the contributing factors of all of those impact a person's health. So I'm going to just spend a few minutes helping you to understand a little bit of those in an individual level. So in terms of economic environment, we have many of our communities that have a lot of disinvestment. When you've got businesses that are leaving, you have grocery stores that are closing up, you have a lot of just disinvestment in these communities. And so what we understand is that the economic health of a community affects the psychological health of its residents as well as the physical effects. And so what are the protective factors? What are the things in the economic environment that protect you from having poor health outcomes? People having the ability to have jobs with living wages and health coverage. Having the presence of banks and stores and other thriving economic and commercial investments. And having home ownership, which leads to wealth building, because in this country, that's where wealth really begins as a part of home ownership. And so what are the factors in the social environment? The degree to which people have strong networks makes a big difference in a person's sense of who they are, if they're embraced by their community. So the ability to have strong connections with neighbors, church affiliations, a strong social cohesion, those things are protective factors. The degree to which communities welcome newcomers and immigrants, the degree to which you feel that you're a part of something. And if people were unsure about the significance of social factors, just think back on Katrina. You know, those who were able to leave had more social connections, people looking out for them. They had to leave. Those who were left behind were those who tend to have less social connections and less access to opportunities to get out of that environment. And again, the fiscal environment, we're familiar with the fiscal environment. This is the degree to which our communities are free of toxic waste, the degree to which we understand the relationship between the built environment. I've heard that you all have heard Dick Jackson speak. He does an eloquent job of helping people understand how we need to focus on how communities are designed, because this has a lot to do with the health of its residents. So we've got to pay attention to how communities are designed. We've got to work with planners and architects and developers. We've got to make sure that communities are designed to have parks and recreation, that we have places for bikes and safe places for having fun together. We've got to make sure that our communities are free of toxins both inside and outside. People would probably be shocked to know, when we were doing research around asthma, that so many of the asthma triggers were found in the homes and the communities and in the schools. So there were no safe places for kids to have fun and for recreation. So we've got to take a look at how do we create a healthier environment for children to play. We've got to focus on having access to grocery stores. We've got to have good infrastructure. Now, many of the work that we do is focused on not just looking at the urban environment, but also looking at some of the rural environments. And this issue of infrastructure is a really serious problem, even right here in California. We've been doing some work funded by the California Endowment down in the Central Valley, where there are just basic lack of infrastructure, that they don't have access to good water and good sanitation. So there are some very basic things that we've got to do in our infrastructure to create better health opportunities. And clearly the services environment. Again, healthcare providers themselves are beginning to understand the connection between where their children who come to visit them live and how they are more healthy or less than healthy. We did interviews with physicians at Children's Hospital in Oakland. It was really a sad interview, because this one pediatrician kept saying that I kept seeing the same child come in the emergency room, and she'd give him the inhalers and do the medicines and send them right back out. He'd come right back in. It was a revolving door, because the child was continuously being affected by the environment in his home and in his school. So until providers see that you can't just deal with the child in that isolated clinical environment, you've got to begin to extend your reach into where the children is having the interactions, which is in the home, in the school, and in the neighborhood. So we've got to make sure that when we look at services, it's not just clinical services. When we look at the degree to which we put schools and child care under services, and you guys clearly know the degree to which we need to make some major changes in the child care and in the education environment. That if we don't begin there, we've got to make